A very good morning and welcome back to Alaigal
Yes.
2025.
Yeah.
Sir Siddhananda sir.
Yeah.
Sir, we are ready for the session, sir. Can we start the session, sir?
Yes. And that is what I tell all my residents, that you need to have a spine. You need to learn to stand up, because the Indian system is such. The day you go into school, you're
Morning,
taught
sir.
never question your teacher.
Sir.
Don't speak up even if she's wrong.
Sir, you are not
And
audible,
then
sir.
that gets
Sir, you are not audible, sir.
you.
Yes, sir.
Am I audible, sir?
Yes, sir, you are audible, sir.
Can we start now?
Yes, sir. Yes, sir. Good morning and welcome back to Alaigal 2025, day 2. We hope you had a pleasant time yesterday and are ready for another exciting day of learning and sharing. Our first session is on anterior skull-based dissection
Yes, I have read it.
microdrill and microdrill by Dr.Ramandeep Virk. I invite our chairpersons, Dr. Palaniappan S., ENT consultant, Sedu ENT Trichy, Dr. John Victor, consultant, NMC Specialty Hospital, Abu Dhabi, UAE, Dr. Balaji CRK, Professor and HOD, SRM Chennai, to introduce the speaker and chair the session.
This is Sanjeev. He's my senior resident at PGI. He's traveled with me. Thank you so much for arranging this. Thank you. Thank you so much.
Hello, you able to hear?
It's a pleasure.
Yeah. Good morning. This is the introduction of Dr. Ramandeep Virk. He's a professor of ENT, JIPMA, Chandigarh, PG, JIPMA, PG Chandigarh, sorry, with academic leadership, renowned for anterior skull base and endoscopic CSF leak repass. And he's graduated in Dayanand Medical College Advanced Fellowship in London. Has delivered a lot of lectures at prestigious international forums, including ARS. Active researcher with strong contributions in rhinology and skull base. Great, sir. Morning.
Hello.
Ramandeep.
Yes, am I audible or?
Yeah, sir, audible, sir.
So, good morning, everyone.
Yes.
We are going to be demonstrating a basic, surgery with the use of microdebriders by Medtronic.
Okay.
Before, we start, we want thanking, the Department of Anatomy, Forensic Medicine, ENT, everyone who has gotten together to arrange this dissection. The cadaver is very fresh, as you will see once I introduce my scope. So before starting, I would like to, give you a brief overview of the equipments we are using. Can we have the view on? We are going to be using a Medtronic microdebrider system. I will come. Basically, this is the brain, all the drills and the burrs and the handpiece attached to it. We have a straight shot M5 handpiece on which our normal this is the normal debrider, what we microdebrider, what we call it, on which the different kind of blades are attached. We are having the 0, the 40, the 60, the 90, the 190 degree, and the 14 degree. These are the various kind of blades that are available for sinus surgery. RPM. This can be changed. So just a brief overview for the youngsters, that how does a microdebrider work. It has a window which opens up, the tissue is sucked in, and then it is cut. So the slower speed, the more tissue it is debulking. So since sinus surgery is a mucosa preserving surgery, we usually work at around 3,500 to 5,000. But if I was doing an adenoid respiratory papillomatosis in which debulking is more important, I would drop the speed down to 500, 1,000 done here. Then it has a forward and an oscillation mode. For microdebrider mode, we use the oscillating mode, which is represented by the OSC. Forward or reverse is for the drill systems when we want to have the blade or the burr spin on the end, one direction. Then it has an irrigation pump. This is very important. In many systems, because of the way they are supplied, CC per minute to less, and your blade is continuously going to get blocked. So we usually start at around 25 to 30, and then we can go up according to our needs. If the flow of the blade will have a good action, it will not with every little tissue that goes into the blade position. This is also very important. Many times when you're doing pediatric cases, if you introduce an open blade into the nasal cavity, the ala collapses because of the suction pressures, the negative pressures that are formed. So you can close the blade when you introduce the microdebrider into the nose. So that is just a basic overview on the handpiece which we are going and the blade which we are going to use. I've also connected an MR8 system. So both the systems are the handpieces are connected together. It is showing me that I have a M5 handpiece currently working and I have a MR8 system on standby. So we have a multifunctional foot switch which is provide chronic equipment, and I can switch between the handpieces. So if I press this button, the MR8 drill becomes active and the M5 handpiece goes on to standby. And this we are using a high-speed drill. It can go up to 75,000 RPM. So we are back to the burr. Can you focus on the handpiece on this? So now I'll show you a brief about the handpiece. This is the Medtronic M5 handpiece, and we are using a rotatable blade with this. How do we know it's rotatable? Because this part is the main part which rotates and moves the inner shaft around. So if I have to rotate the blade, we unlock it. We can have a different direction of the. As I'm inside, it will be more clear. I'll be able to show you better. It has an irrigation port. It has a suction port. And this is the MR8 piece with a skull base attachment. I will use this as a demonstration when I open up the sphenoid sinus. There are multiple ways to open the sphenoid sinus. This means that this is the only burr or the drill which can open it. Normal burrs can also open up the sphenoid sinus along with other instrumentations. Plus camera system. And we have an inbuilt light source and camera system in it. It has an optical zoom and it has a focusing ring present on the head unit. It is very important to know your equipment because many times we have seen the surgeon completes the surgery without even adjusting the fine focus. You go up very close to the tissues, it is very important that you refocus again. Though for majority of the surgeries, you don't need to touch the focus once it's done. But when you're very up close to a structure, fine focusing needs to be adjusted. So with that, we will start our demonstration.
Ramandeep, have you able to hear?
Yes, we are able to.
Can you show the tip of the burr? Because you have told the terminology, there's a closure and opening.
Yeah. So I'll show it once the microdebrider is inside. There it is.
Yes.
So do you see the window which is there?
Yes, sir.
I can change the direction. And do you see these little arrows which are marked? The black arrows on the burr, on the blade.
Yeah.
So these are present on all microdebrider blades. The reason why they are given is, let's say you are debulking a tissue or tumor.
Yes.
And normally I can see the tip and the cutting surface.
Great, sir.
But if it is buried inside, I will not be able to see it.
Yeah.
But the arrow will tell me which direction the cutting surface is.
Yes.
System which is
So when you are introducing, you have to close it, no? The serrated end. The serrated end. When you are introducing into the nose.
Right.
Yes. So it is a zoom.
So it has to go in
Thanks to Medtronics.
for supporting. And you can open the blade
Yes.
with the foot pedal. See?
Yes. Great.
So this is what I was saying, that when you're doing pediatric cases, this nasal cavity is very small. The minute you introduce an open blade, all the tissues get sucked in.
Yes.
So in those
Thanks to
cases,
Olympus and Medtronics.
for both the sponsors for giving us this equipment.
And the Department
So I
of
will-
Anatomy, the cadaver is also looking very fresh.
It's very fresh.
We are going
So
to
I've
see
just
the
packed
bleeding.
it with. Yeah. So I've just
Thanks
packed
to the
it
organizing team. Yeah. Great.
could do any normal, endoscopic sinus surgery.
You used to keep a mirror,
So- We had come early in the morning. We had kept seal then. It just kind of, because the cadaver
Yes.
is. So I'll just identify some. First of all, you go straight back ahead to the choana. You can see the choana
Yes.
very clearly. You can
Very
see
clearly.
the nasopharynx.
Yes.
You can see the torus tuberous.
Torus
and you
tuberous
can see
eastern tube.
the opening, right?
Yes.
So coming back to the front, kind of coming into your
So in the middle, voice is breaking.
So there are ways you can actually create more space. We start by infracturing the turbinate till you using full long end of the elevator, push it back.
Okay.
Space that gets created.
Yeah. In
Your
fracture.
whole
Okay.
lower part opens up. So you in fracture and then you out fracture.
Out fracture.
But make sure you don't use the sharp surface. If you use the sharp surface, this turbinate is going to start, and since they have very vascular structure, will ruin your surgical field.
Yeah.
You use the long shaft, like maximum contact with the turbinate of
Yes.
the complete elevator, and then you just gently push it back.
Okay, sir.
To open this space, so I have gently out fractured the middle turbinate.
Yes.
Make sure you don't overdo it, because sometimes the attachment can be at cribiform and you can have a CSF leak which you don't want. And then we put a few pieces of
Gel form.
that you can
surgery,
see the
yes.
normal structures. So the maxillary line.
Yes.
This is the
Uncinate process.
uncinate process. That is the free border of the uncinate
Uncinate,
process.
yes.
And this free border is the one which we will target. Okay? Get
Yes,
to
sir.
the frontal sinus. It is very important to remove the uncinate in its totality.
Yeah.
Many times this upper part of the uncinate is left intact, and then you are not able to get into the frontal sinus.
Close to the axilla.
Going further, yes, close to axilla. Then going further ahead, we can see the bulla.
Bulla. Yes.
Very carefully. When you are opening the uncinate or cutting through the uncinate, make sure you don't damage this.
Yes.
So make sure you damage the bulla, because if this opens, then one of your landmarks is
Yeah.
lost. Going back, this is where the middle turbinate is going to turn,
Yes.
and this is called the basal lamella.
Basal lamella. Yes.
Okay. Another thing, if this space is not enough, you can do what is called a BRI, or a basal lamella relaxing incision. What we do is we gently take an elevator and we open this area up.
Yes.
This. Once you do this, your middle turbinate is the septum.
Yes.
So this is called a BLRI, or a basal lamella relaxing incision. Make sure your elevator is not pointed to upwards, or you have chances of going into the skull base.
Skull base.
Beginners, we always say that make sure you see the floor of the nasal cavity and parallel to it,
Yeah.
because in that way you will be safe in all corridors. Problem happens when operating, my endoscope keeps on going up and my instruments keeps on going up, and then we enter either into the cribriform or the roof of the posterior point.
Yes.
Okay.
Yeah.
Sphenoid sinus. The two sinuses which we as beginners fear are the sphenoid sinus and the frontal sinus.
Yeah.
Maxillary, okay, voids are okay, not too much. So we have two corridors to open the sphenoid sinus. We have the medial corridor, which runs between the septum and the middle turbinate. And then we have the lateral corridor, which runs through the middle meatus.
Yes.
So I'll be demonstrating both corridors. The reason that is, if I am dealing with the CSF leak in the sphenoid sinus, I don't need to go in destroying all the normal anatomy of the middle meatus.
Yes.
If I need to take a biopsy from the sphenoid sinus, I don't need to open all this. In that case, I will just go through this corridor. So for that, the easiest is, can I have a small merosil? I gently lateralize the middle
This is a
turbinate.
transnasal approach of sphenoid. Yes.
Using the medial corridor.
Medial
So I
corridor.
gently
Lateralize the middle turbinate.
lateralize it.
Middle
And the
tab-
first structure I identify is the superior turbinate.
Turbinate, yes.
Okay. So once I
So
I
when you
put in a
lateralize
piece
the
of-
middle turbinate, you will be seeing the superior turbinate. That is
Superior.
very important.
and that is important because the sphenoid ostia will lie
Ostia, yes.
behind it then.
Yeah. Just medial
That
to
will be
the.
the natural ostia.
Yeah.
Stenting it with merosil actually benefits us. And then the lower end of the middle
Lower.
turbinate gently out fracture so that I get a good space.
Yeah.
Once that is done, I push this between the superior turbinate and the septum
Septum.
to decongest.
Towards
The
the sphenoid
natural
nodal
ostia.
rhesus. That is the important area. Okay.
Correct. And I can see the superior turbinate. You
Turbinate,
see the
yes.
superior turbinate?
Yes, sir, yes.
Superior turbinate.
So concentrate. This
So
is
once
very
this-
important thing. Yeah.
So once this is done and this, merosil has decongested the natural ostia, you will be able to see the natural ostia of the sphenoid sinus. So that's the natural ostia of the sphenoid sinus. So the coana and straight ahead up on the coana, the superior turbinate and the lower part of the superior turbinate, you lateralize and you open the natural of the sphenoid sinus. Is it clear?
Yes, sir. The voice is breaking in between. Actually, he is telling this superior turbinate, you have to concentrate on the lower half of the superior turbinate, you have to resect or you have to lateralize, then only you can see the sphenoid os.
Correct.
Great, sir.
So you can gently widen it. Okay, at this stage, we usually use a ablator and we remove this mucosa on the face of sphenoid.
Yes.
There are vessels here which are branch of the sphenopalatine, which our Haddad flap is going to be based. So, and for the Haddad flap, if I'm to a Haddad flap, I have identified the ostia. I will start making an incision which will come towards me and then start going slightly upwards. Can you see?
Yes.
I'm not making the incision, I'm just marking it out. And once you are at the midpoint of the middle turbinate, you can start to go up.
Go up.
You don't go up in this region because of the olfactory mucosa. You don't want to take out the olfactory mucosa and cause smell disorder. So from this part, I come out straight till I'm at the midpoint of the middle turbinate and then I can go upwards. And then come forward, go down till the nasal. If I need a bigger flap, I can take part of the nasal mucosa also and make an incision here. That clear?
Yes, sir. And here, many PGs are here. So, he is talking about Haddad Bazagave, that is Haddad flap. So, from the sphenoid os, you have to draw a horizontal line, but it should be below because you have to protect the olfactory nose. Then up to the middle turbinate level, you come
Midpoint here, then you can go up.
Then go up. Anteriorly,
then
how
you
far
can
you will
come
be coming
That will depend on how much you need,
depends. Okay.
the area. And it's always better to take a larger flap because if it becomes a shorter flap, you can't do anything.
Yeah,
If
yeah.
it's a larger flap, you can trim it later on. It doesn't matter.
Inferiorly,
And inferiorly also, depending how much you need, you can come up, you can take the mucosa from the nasal floor also. You
Yes.
can go up the wall of the nose also.
Yeah.
These are all extended flaps.
Extended
It will all
flaps.
depend on what surgery you are doing, how much is the defect you are planning to fix.
depends on the defect size.
Yes.
Yes.
So is that clear now?
Yes,
so
sir,
I will
very
start
clear.
with, so let me start with opening of the sphenoid, and then I will from the other corridor. So like I said, we take a coablator, or if you have a cautery, or even if you have a monopolar or a bipolar, you can ablate this mucosa away.
So
The
can
reason
you
for doing that is,
So can you appreciate the change of color of the olfactory mucosa and the normal mucosa in the septum there?
in patients, no, you cannot actually. But in fresh cadavers, we will be able to show you the olfactory fibers also.
Ramandeep,
Yes, sir.
here, Padmashri Mohan sir is here. Morning, sir.
Morning, sir. So I'm going to start widening the sphenoid ostia. The safest place to widen is, you can widen it towards the septum. You can go downwards, right? That would be a very, very safe area where you can open it. Okay, and then once we have opened it wide enough, we will go inside and try to figure out the anatomical line. So, do you have a smaller on you? No. Okay. This is a large ronger. Normally, size 1 works well here. I can use the drill.
Ramandeep, when you are dilating the arse downwards, in the reality there will be a bleeding, no? How will you control that
is why-
bleeding?
That is why I said, sir, your first step is ablating the mucosa all around so that your field is clear. So it can be done with the bipolar cautery, it can be done with the monopolar on a suction, and it
Yeah.
can be done with a coablator. Which is a coablator because it's clean field.
Yes, yes. It's very important. The lower part, there will be bleeding. So you have to control with diathermy, bipolar.
Yeah. Or a
Only you
coablator.
can- Yes.
Suction. ठीक है, डाल.
Now he is dilating the arse, sphenoid arse, downwards. Because wide exposure is very important.
It's the key to any surgery, whether you're doing
Yeah.
a stapes surgery, whether you are doing a, functional endoscopic sinus surgery, any kind of surgery.
Yeah.
Good approach is very important.
Yes.
And you need, so there's fresh secretions also.
The safer thing to dilate the sphenoid arse inferiorly and medially.
Yes. Because medially we have the septum, we know that.
That's enough.
Inferiorly, if I damage something, I have esophagus, I'm not worried about
Yeah.
that.
In many cases, we are going to do
And-
posterior septectomy. So nothing to be worried.
Worried about.
Yes. So you are using a kerosene now. That area or
No, sir, I'm using a
Yeah, yeah,
MR8
yes.
drill,
green?
high speed drill.
High speed drill. Yes.
So in normal circumstances, I would love using a coarse diamond here.
Yes.
It
Post
gives me
diamond.
more controlled, coarse diamond gives me a more controlled opening of the bone work I need to do. Actually, the kerosene I just wanted to, show you with the drill.
Okay.
So now I'm going inside.
Straight away, we are able to see the sphenoid posterior wall.
Bus,
Yes. Cella area. Clivus.
that area. Now when I open it upwards, now I can see the roof of, and I still have space upwards. So I can save or take it down with a slightly upwards also. Can you reduce the irrigation to 30? In different sizes. You can now even shift over to a larger burr.
Okay.
So this mucosa in real life is going to bleed terribly.
Even here, we are able to see the bleeding. It shows the cadaver is very nice. The organizing team, great. Anatomy department.
For arranging this.
So this is very, very important for the demonstration. They are given a very nice cadaver and we are able to appreciate the bleeding. So can we give a small applause?
Round
for
of
the
applause.
team? Yeah, great. Ramandeep, able to hear the applause? Convey the wishes to the anatomy team.
Yes, sir.
Thank you.
So in
So if I'm
cases,
going to take, that is the again.
so in cases where we don't have the landmark, so if you open the sphenoidal sinus, we can see the level of the planum sphenoidale and then proceed anteriorly.
Correct. So this is what I was talking about. The sphenoid is, the opening. I had to create a little bit wider opening because of the raunges.
Yeah. Sir is using a kerosene.
Yeah. Now I'm using a kerosene.
Yes.
A powered, more controlled, opening since I'm not stripping the mucosa away.
Yes.
Elevator. So I'm trying to maintain all the anatomy of the inferior turbinate. Otherwise, I can cut this lower part of the inferior turbinate to give a
Middle turbinate or?
inferior turbinate.
Oh, great.
So now we are in the sphenoid sinus. This is probably a deviated
Septum. Intersphenoidal septum.
intersphenoid septum. Yeah. So if I have to take a biopsy, depending on if I have to repair the CSF leak from the roof, I can keep on going upwards and creating more space. I can do a posterior septectomy. I can do a limited septectomy in this area. Okay,
Yes, sir.
Ranger. So I'm going to open it a little bit more and 0 degree debrider. And I'm going to trim out the part of the superior turbinate just to give me more space.
Yes.
Goes straight up. I cross check with the arrows once. I can see the cutting surface very clearly.
Yeah. Great.
It's blocked. The blade is blocked or the suction is not working. Check if the suction.
So now he is removing the inferior portion of the superior turbinate. Inferior half of the superior turbinate. So that he can easily dilate the sphenoids.
So do you see the superior turbinate?
Yes, yes. Nicely seen.
So this gives me more space actually,
Yes.
and I'll be able to see laterally.
Yeah.
So I can see I've opened a cell
Cell.
which is going into the sphenoid sinus.
Yes.
So this might be a serum, this might be an OD cell.
1 1
Yeah. So we can only clarify once we have seen the scan.
Yes, yes. Yeah.
Because, so I will mark out that cell for you. This cell that I have opened.
Yeah, great, sir.
Visible, if I open this part of the cell, I will
Optic now.
be the
Optic.
optic.
Now.
Because once I'm in the sphenoid, I'm not being able to see the optic nerve, which should have been visible by now.
Yes.
Okay, so is that clear? So any biopsy I need to take.
clear.
And if I need to do a septectomy, later I will remove this glucosa. I will drill out the part of the bone,
Yes, sir.
do a septotomy or a septectomy, and I will be able to see the natural osteo on the other side.
Yes.
Okay, so if you have time, I can demonstrate how to go to the from without being binostril.
Okay.
Elevator. Now we are going to do a lateral approach. Again,
So this is transnasal approach. Now he is going for a transsigmoid.
ball probe, please. Okay, again check the nasal floor. Keep on checking your orientation. It happens even with the best surgeons, this orientation. Just like it happens.
Here, this is very much useful for the PGs. There are 3 different approaches. That is transnasal, transethmoidal, and transeptal. So he has finished a transnasal. Now he is going for transethmoidal.
So this is the uncinate process.
Uncinate
Uncinate process has 3
Yes.
parts. The horizontal part and the intermediate.
So it is having a vertical part and the horizontal part. Yes, sir. Great, sir.
So I'm just going invert it.
Yeah.
a little.
Mr. Voice
So
is
this has to be
breaking.
done.
Yes.
This has to be done very gently. Otherwise,
voice
there'll
is
be a lot
breaking,
of
sir.
bleeding.
Ramandeep sir, mic close to your
Yes,
mouth.
sir. Backbiting.
The mic
Backbiting.
close to your.
Yeah, mic is actually okay. I think issue with the transmission.
Yeah, transmission.
So I've just everted it out a little bit so that my backbiter can engage it.
Yes.
If it is lying flush like that, my backbiter will have trouble
Great,
engage.
sir.
So open the backbite once per inside this meatus.
Yes.
Don't open your back, take it, you're going to injure the septum or the turbinate and cause bleeding.
Right.
So go inside, open it, rotate your hand clockwise, engage the uncinate, and go infero-medially.
Yeah.
And you take one bite. Again, rotate it back, open it,
Yeah.
re-engage.
This is hiatus seminaris inferioris. Here he is doing the work.
So I've taken 2 bites, no more than 2 bites.
Yes. See, yesterday they had told for the PGs, you should not go too much forward because you
Because
may
you'll injure
damage the
the
nasolacrimal
nasolacrimal
duct.
Correct. So once that part is removed, you separate the vertical and the horizontal part because the intermediate part is gone and this part becomes loose.
Yeah.
You see this part?
Hiatus seminaris
is-
inferioris.
That's the horizontal part. And
Yes.
you are in the maxillary antrum. Do you see it?
Infundibulum, then maxillary antrum.
And see the direction of the opening of the maxillary
Yes.
antrum. It is horizontal. It is not vertical.
Vertical.
So just with these 2 bites and with a 0-degree endoscope, you can actually look into it.
Yeah.
Then you go ahead removing the uncinate process. So I'm going to use a 40-degree blade. The ideal blade here is the 14-degree, 1/4, which is called an uncinate blade. Do you have that? They have the 14-degree. I can show it to you if you want. Nahi? Nahi. Okay, no, they don't have it. So I'll use a 40-degree blade. 40-degree blade has a little steep angle.
Yes. We can see the serrated edge.
Right. So this is called a tri-cut.
Yes, sir.
It also smooth edges. It's called the bullet, I think. What is the arbitrator blade you have? Okay. So these are the tri-cut. These are aggressive. See those sharp teeth. These are called the tri-cut blades.
Tri-cut blades.
So I am
He's
removing
doing
the
uncinectomy.
uncinate.
Uncinectomy he is doing.
If you don't have a debrider, it can be done with a through cut also.
Yeah, through cut. So always through cut forceps are better than the normal Blackersley.
Yes,
Well, we should
because
not
they will
pull
cut
the-
and crack.
Yeah.
Time.
All the through cut blades are good. Through cut forceps.
Now I'm having little difficulty engaging this blade because I'm going to engage the bulla.
Bulla, yes.
So the way to avoid that is you use a J curate.
Yeah. Now sir is going to use
And
the
you-
J curate.
And pull the uncinate towards you.
Yes.
See that?
See here he is using J curate because of the upper attachment of the uncinate. For
And
doing
if I
this,
try
we
to
have
push
do-
my
Yes.
debrider, it would have gone into the bulla. Can I have upward through cut? Up. So if I have an upturn through cut, I will show you how to cut it. If not, that is okay too.
Yeah.
No. It's okay. I'll do it with the debrider only. So once that is there, now you can see that my blade will go safely between the bulla and the uncinate.
Uncinate.
I'm not injuring anything.
Yeah.
This step actually helps to clean your keep your field clean.
Yeah,
If
yeah.
I'm continuously hitting bulla, it becomes horrendous, especially for a beginner.
Yeah. For the beginner, it is also important that is a uncinate attachment, whether to the middle turbinate or to the roof of the that is upper attachment. We have to see everything.
Yeah,
So preoperative CT reading is very important.
very important. So, and you have to remove it completely, the uncinate.
Yes, sir.
That is how the orbit wall will come into view.
Yes. Now the bulla is in the view.
Now you can see the bulla, but this part of the uncinate is still attached.
Yes.
So I can just gradually pull it out with a upward leg. This part of the
Supraaxillary
turbinate
area.
attachment tends to bleed.
Bleed, yes. So how will you control that bleeding, sir?
Just keep patience. Put the piece and leave it there for some time.
Okay.
Force it upward.
Because that is very important area, because to do the frontal work, we have to do the work in the axilla area.
Upward leg sleeve. No, I need a upward leg sleeve.
Usually it
Separate
bleeds.
it out. So any questions till now, or
Any question
on the
from the
steps which-
PGs?
You can keep your instruments closed. Don't open them and never introduce a instrument like this. It will damage the septum. It will damage the lateral wall. It has to go parallel, closed, and straight.
Ramandeep, sir?
Yes.
Question from Professor Prabhu, sir. He's asking to control the bleeding, can we use a cobblator or bipolar cautery in the
Yes.
supraaxillary area?
Yeah, you can. I mean, there'll be some stenosis, maybe not later on, but controlling the bleeding is the most important,
Yeah.
because you have a risk of damaging structures. I mean, synechias and other stuff you can
Yeah,
still.
No. So this is very, very important. We should not produce
Manage.
any synechia or scars in that area, because it may block the airflow tract, the frontal sinus area.
Okay, now I'm going to shift to an angled endoscope. I will
Yes,
do
sir.
an intact bulla technique of open. So what is an intact bulla technique? For beginners, ball elevator there, please. Thank you. So
this
for beginners, if I open the bulla,
yes.
I will important mark. In intact bulla technique, I have the bulla posteriorly, I have the orbit laterally, I have the middle turbinate medially. There is only one place I can enter, and that will be frontal sinus.
Yes.
But that will depend on the kind of pneumatization the
Pneumatization,
frontal
yes.
sinus. So that is why it is very important to read your CT scan
CT is very important.
and
You have
how
to see
large
the
is
frontal
the
beak, frontal rhesus, everything.
and how large is the agar. So do you see side?
Very nice.
And you can see the attachment of the agar. Also-
Nice. Yes. So the axilla should be intact, and behind the axilla we have to work to see the frontal rhesus, aga nasae, and the frontal sinus ostia. This area is very, very important, because we should not create any raw area, because postoperatively synechia will be there. So
Which will be
here he
troublesome.
is using a ball probe like that, no?
So do you see this cell?
Yes, sir. Yes, sir. We are able to
That
see
is
this.
the edge of the agar.
Okay, great, sir.
And you just need to uncap this.
Yes. See, this is very, very important. We should not damage the mucosa here.
Yeah, that is
Yes.
why I'm doing it very gently.
Very
as if
gently,
it's a
very
real
gentle
surgery.
movement. Yes. Always frontal sinus walks are should be very gentle.
it. J- So I'm gently uncapping it as I would do in a live.
Yeah.
And I am in the
Yes.
Frontal sinus.
Great, sir. Great, sir.
So identifying the agar, if you have controlled your bleeding, you can easily see the free surface, free edge of the agar.
Yes, sir.
And you just need to introduce your JQ or a ball probe
Accurate or pulp.
and see the mucosa of the frontal sinus. I have not damaged it.
Yes.
It is lying intact. If I'm going to injure this frontal sinus is going to still an intact bulla technique of opening the frontal sinus. Ball probe. So I'm going to,
Sir, can you dilate it and can you
So
show,
just a-
show the posterior?
yes, I'm going to show that.
Yes.
So there is only, if you go but enlarge the frontal sinus, you can already see the posterior table here.
Yes. Posterior table. Yes.
Okay.
That's very
If you-
important.
Yeah. If you go laterally, you are going to end up in the orbital area.
Orbital. Yes.
And you can't go medially because you will have the skull base. So the
Skull
only
base.
area it can be safely enlarged is the nasal beak,
Nasal.
the frontal beak.
Frontal beak area. Can you show that area? Frontal beak area, exactly. With the ball probe or something.
Yes. So this is the front area, this one, which it's usually thick,
Yes.
okay?
Yes. Sir. So
This
there is
area,
an
this
inverse
area is the-
relationship between the frontal beak and the agar cell. If the agar cell is big, the frontal beak will be small. If the agar is small, the frontal beak will be big.
So now you can see the posterior table of the frontal sinus.
Yes, yes.
Okay? And again, the mucosa is still more or less intact. We have not disturbed it.
Yeah.
And you can still see a cell covering ball probe. So you can still see this covering of this
Yes.
agar cell. You can get it out, right? And this is the frontal beak. Do you see this?
Yes, yes. We are very well seen. Frontal beak.
You get specialized burrs
Yeah.
with which you can and lateral end. I have
So
not
it is
disturbed
very, very
it. I've
important
just-
frontal beak area because we have to work in that area in case of draft 3.
You have a 90-degree no 90-degree ronger goes up. Forward ronger is like a 90. This instrument
Yes. Is it multi-jointed or a? It's angled kerison.
Yeah, it goes into the frontal sinus. And then you can bite out the
Bite.
beak area
Yeah.
like that. Do you see that?
Yes, yes. Great. Now he is dilating the frontal sinus ostia with the help of a multi-jointed. It's a type of kerison.
I'm going to clean my endoscope up. I'm going to show it. So see, we area wide. And now you can see inside, you can see the scalloping. Is it clear?
Yes, sir.
Endoscope is a little busy. I'm going to clean it. I'm going to...
Ramandeep, sir,
Yes, sir.
only 45 minutes more. So please go ahead.
Okay.
Yeah, thank you.
So that is the posterior table. Can you see the posterior table?
Yes, yes, sir. It's very important.
The
We should not
white
damage
bone.
it.
Yeah. And the mucosa is still would be operating in a light case. There are some secretions which are lying in the frontal sinus.
Yeah,
You agree?
yes.
So your frontal sinus and sphenoid sinus, two sinuses which beginners are usually scared of, been dealt with.
Yeah.
Straight blade. So when you are starting out for angled end, we usually tell the beginners to start with a 0 degree and a 30 or a 45 degree, never with a 70 millimeter. Check.
So for the surgical work, we should not use this 70 degree. That is only for diagnosis.
For beginners.
Yeah, for beginners. Yes.
Once you are experienced, then you can.
Then you can use this 70 degree.
Okay, so we are inside now. So to remove the bulla again, you can have multiple methods. You can do it with a J curate.
J curate.
You can, yeah. So that's the basal lamella. You can introduce the J curate between the basal lamella and the bulla, and you can pull it forward.
But it should be in the inframedial aspect.
Correct.
Yes, great.
And the issue when you're doing bony work with the microdebrider is going to get closed repeatedly.
Yes, yes.
So the bulla is opening up, and you can remove the bulla
Yes.
till the orbital wall.
Yes.
And that is the upper part of the bulla that I can do with an angled endoscope later on. Do you see this part?
Yeah, yeah.
This is still intact. Give me a J. Accurate, please.
Now you are able to see the septations in between.
Yeah.
But we have to be careful when you are using, because repeatedly you cannot use this fan. So to use
And
the
you have to
debrider
be-
blade, mucosa touch is better than bony touch. If you are touching bone repeatedly, the life of the thing will be out. And it is costlier, no?
See?
Yes.
Now the bulla is out. And
Yeah.
what do we see here? That is the basal lamella.
Basal lamella. Yes.
Okay?
Yes.
So where do we enter the posterior ethmoid?
Again, inframedial.
Very right.
Always
So it is-
inframedial is better.
Yeah. The lower you are, the it is actually, because if you are very low, what is going to happen? You are going to end up in the nasal cavity.
Yes, yes.
There is no worry with that. Okay? But if you are superiorly, you will enter into the skull base. Which, especially if you are a beginner, is going to shatter your confidence. The posterior ethmoidal cells are used. I'm just removing the bone, then I will take care of the mucosa. This is just mucosa that is left.
Yes.
This mucosa, you can see the opening in it. I'm punch it now and open it.
So when you are opening the basal lamella, you will be entering into the posterior ethmoids. Again, the posterior ethmoid area, if you are working inframedially, you can go towards the sphenoid sinus. That is transethmoidal approach to the sphenoid.
Yeah.
So now
So now
two
you
approaches
see-
over, transnasal and transethmoidal towards the sphenoid.
You can see my sphenoid sinus.
Yeah, great, sir. Great.
So the posterior ethmoidal cells are single and large.
Yes.
That is very important.
Ramandeep, can you hear me?
Yes, sir, we can hear you.
One question, what speed you are using in the debrider machine?
5,000 RPM. 5,000 RPM.
5,000. Okay.
Yes, sir.
Always, or you reduce the speed also?
If I reduce, I tend to take more out. If I'm doing skull base work, I will put it in lower speed so that more mucosa can be taken out.
Exactly.
Because skull base work will not be a mucosa preservation surgery.
Exactly.
But if I'm doing normal functioscopic sinus surgery, then we would like to have 5,000 RPM as the
Higher speed. Okay.
Agreed. So that
And
question
look,
was from
I'm not
Agil's- yeah.
I'm not blindly pushing in my debrider blade. I can see where it is cut. I can see the arrows. I'm up
sir,
close.
sir, can you hear me, sir? Ramandeep, sir. Yeah.
Yes, sir.
Delegates want anterior ethmoidal and post-ethmoidal artery entry into that area. Just can you demonstrate for the benefit of postgraduates, sir?
Yes, I will. Once I come up to that part, I will.
Yes.
I have left these tissues intact.
Okay, thank you, sir.
I'm just doing a straight head-on work, just doing a basic, anterior and a posterior ethmoidectomy. So your orbit, lamina preparatia is a very, very consistent landmark. Okay, now I'm going to remove the and see what kind of cell. So I've uncapped that cell, which was not letting us see the optic nerve. It's probably an OD cell. And there is the optic nerve. Do you see it?
Yes, yes, great. Able
So
to see
this
the
is a
optic now.
classical anode cell.
Yeah, one
That
node.
is why when we were looking through the sphenoid sinus, we could see this division, and that which over part of the node cell. That is why we could not see the optic nerve.
Optic nerve, yes.
Blade is blocked, please. Give me a through cut, straight. So we can also use a through cut here to remove this mucosa and the thin bone.
Always it is better to use a through cut. Because we cannot believe, because inside the sphenoid sinus there are a lot of septations. Sometimes it may get attached to the carotid area, carotid prominence. We have to be careful. So through cut instruments are better than regular instruments.
Yes. Through cut instruments are always better than regular. Care of the septation.
Yes, yes.
I'm using a microdebrider, but in real life I would be a little more careful.
Yeah. For the beginner, we should not use the microdebrider inside the sphenoid. We have to be
Sphenoid
careful.
sinus.
Yes. Cold steel instruments are better.
So we have uncapped the node cell.
Yes.
I'm removing the last of the septation, and you can see the optic nerve.
Yeah.
So this is why this node cell is dangerous, because the scan
case of-
carefully is going to go straight through it, thinking it's the posterior ethmoid,
Yeah.
and it's going this nerve is going to get injured. And in many cases, it doesn't have a bony canal over it. It's,
Yeah. In
it's
4%
lying
of the
descent in
cases,
the-
there may be dehiscence. Cannot dehiscence.
Okay, so this is a basic work. If a junior can do this basic work, it from the anterior posterior ethmoids, you have cleared the coana, you have cleared the sphenoid sinus, you have opened the frontal sinus. Now the cells which are left are on the axial cuts. What you see, the upper ethmoidal cells, those are the ones that usually get left by beginners. So to get to that, let's try to see the skull base. So this upper part, white bone, is the skull base. Accurate?
35 minutes more.
Yes, sir. We'll finish before that.
Yes.
This is the skull base. Okay?
Yes.
So once I've identified the skull base, I know I don't need to go higher than this, and these all septations can be removed. Okay? So I can do this with a microdebrider, or I can do it with a curate. So gently, you can just uncap these cells. I can also do it with a ronger. I can also do it with a upward through cut.
Curved section tips also.
Yeah. Whatever works for you.
We are able to see
So
the
you
sphenoid
can-
sinus, lamina pepperica, everything.
Debrider upward ready kar do. So I'm gently removing the bone. Patience is the key for a good clean field.
Yes.
But see how instruments, this does not happen with a microdebrider. And there are still some septations left on the lateral part.
Yeah.
You can make them flush with the orbit. Again, all sinus surgeries don't need to be a full-out space. It depends on the disease, how much disease the patient is having. So see, this is the skull base. I'm just working on removing these septation. The debrider is going to get blocked. We know it, because the bone chips tend to. And these were the upper ethmoidal cells I was telling you. And now you can see the white skull base coming into view.
Yes.
I'm still using the zero endoscope.
Yeah.
Okay. For beginners, it gives them a better orientation, because you are looking where your instrument is going and as the instrument is going. It's not angulated. So these septations can also come off if you want to do a complete job. Okay. So once again, that is the optic nerve,
Yeah.
this part. If I had to decompress the optic nerve, I will need
For the
to take
juniors, it is very important when you are going nearby the optic nerve, don't use a powered instrument. You have to be careful. Ramandeep is a well experienced person. So for him, it is like a toy.
No, sir. Still very careful. I respect microdebrider more than you know anything, because if you don't respect your instruments, they will not respect you back. J curate. So I can see the frontal sinus.
Yes.
I just have to uncap the upper ethmoidal cell. Then I should be able to see the below which the interior. So we don't know in this case how it is running. So do you see the fovea has come into view?
Fovea is coming into view. Yes.
So fovea is just a depression. Behind the fovea, the head of the fovea is the frontal bone.
So this is very important. Now he is defining the fovea.
There is the interior ethmoidal artery. Do you see
Because
it?
frontal sinus opening, just posterior border is the anterior ethmoidal artery.
Well,
Yes.
that's
That is
the
the
interior
anterior
ethmoidal.
ethmoidal artery. Yes.
So see how gently we uncapped it.
Kept. Yes.
No hurry, preserve the mucosa. Max, I can use a microdebrider to get these tissues and these bone pieces out.
Yeah.
So, like yesterday, in the panel, they were discussing you injure it. So, it will depend where you have injured it. Okay? If you have injured it close to the cribriform plate, it is going to retract intracranially. If you have injured it close to the orbit, plate is blocked. It is going to retract. So, that is your frontal sinus above.
Yes.
Do you see it?
Very nicely seen.
Ball probe. Then I'm going to show you the fovea. That is the fovea.
Yes.
That is one cell. We can open this up, but I've just preserved the mucosa. I'm just showing you how mucosa is preserved. And you can see multiple branches of the anterior ethmoid. Do you see them?
Yes.
So it is not a single vessel most of the time. It comes out of the orbit. Okay?
Yes, sir.
Easiest way to see it on a scan is where it is closest to the medial rectus and the superior oblique. It will exit that, run in the roof of the nasal cavity, then it pierces the cribriform plate here, making it one of the weakest areas.
Yeah. Again,
Okay.
based on
Then
this
it
anterior
runs-
ethmoidal artery also, we are elevating some flap mucosa, like hadad
Yes.
flap.
Because then
Based
it
on
will
the-
go into the intracranial cavity. It will
Cavity.
run in the ethmoidal sulcus, give
Yes.
a branch to supply the fox cerebri,
Yes.
will come out of the intracranial cavity and
Cavity.
supply the anterior part of the septum. And this is the interior part of the septum, which is based on the anterior ethmoidal artery.
Based on the anterior ethmoidal artery. Yes. There is another flap.
So these cells can also be taken out. Do you see these septations? I can take them out with a microdebrider. So microdebrider always preserves mucosa.
Yes.
And if you use it carefully, it is not a dangerous tool.
Yes. But very close to the anterior ethmoidal artery and posterior ethmoidal artery, it should be like
Yeah,
a
that
feather
is the
touch.
anterior ethmoidal artery.
Yes.
Okay. Once we have the face of the sphenoid, this will be the region of the posterior ethmoidal artery. Now, posterior ethmoidal artery usually many times it deep in the bone,
Yes.
so you might not be able to visualize it.
Yes.
More so, the posterior ethmoidal, anterior ethmoidal also run deep in the bone, but mostly it runs in the entry, and we are able to identify it. So, if I work between the anterior and the posterior ethmoidal artery, That approach would be a transcribiform approach. Okay, so we can remove this bone, enter into the space.
Ramandeep sir,
Tumor work. Yes.
sir, here it is a dissection. So here Prabhu sir wants you to break the anterior thymod artery and to show the things for the
Sure,
PGs.
Elevator. So number one, create space first,
Yes, yes.
and then elevate the mucosa.
Great.
And you need a sharp, elevators which are slightly angulated. I'm lifting the mucosa so I can use my microdebrider blade. Debrider blade. Upward forceps be ready. Kar. Thank you. Just be with me. So I've just lifted this mucosa off. I want to show you it in its totality without injuring it.
Yes.
It's very easy to injure it because in dissection you tend to get carried away. Since you know there'll be no complications.
And this area is one of the common areas for idiopathic CSF rhinorrhea because it's quite weak.
Yeah. It's thin.
Yeah.
So I have removed the mucosa, and do you see it moving?
Yes.
And it is still covered in bone here. Okay? Sorry. So I'm dissecting it from the medial end now. I'm just getting the mucosa out. Bit suction, please. So do you see it now? Post up. So for the 45-degree endoscopes works best here. So I'm just, so do you see why I lifted the mucosa? Because I wanted to get in totality there. So do you see its branches?
Yes, 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 yes. Very
We have
nicely
a
seen.
branch go lower. We have a branch which is going upward.
Upwards, yeah.
Ball probe.
Yeah.
So we can uncap the bone on it.
Great.
So see, it's still in
Very
bone.
nice demonstration, sir. Yeah.
But still in the bone. If we have a curate, we could easily have, lifted the bone up. Give me that circular knife. जो पहले दिया था, C knife. So I'm just trying to get the bone off so you can get a gist of the. And again, I'm trying to be as gentle as possible. I don't want to open the vessel, as I would not want it to be opened in real life.
Yes.
So controlled movement of hands is very important. Majority in with us, they are glued to the screen. I always tell them it is very important to see how an experienced surgeon hands are working. So this bone chips we are removing. So it's thick bone. And there is your vessel. It's thick bone. I mean. Okay. So most of it is out now.
Yes, yes.
And I'll show you. I'll see if I can lift it out. All probe will not go under it. I need a.
We are able to appreciate because 25 minutes more. Yeah, very nice.
Where you still have some blood in it. Okay. Okay. So now I can demonstrate a septectomy
Yeah.
and how we go on to the other side, straight debrider blade.
So now he is
Elevator.
going to create, I think, septal window for draft procedure.
Yes. Can I have a blade? They want to see her dart up. I will,
Time limit is 24 minutes.
we will adhere to that.
Yes.
So like I said, it usually starts, now the sphenoid ostia is wide. So
Okay.
we have lost that landmark. But we still know the vessels are going here. So slight.
Phenopelladin branches are going there.
Yeah. So once I'm at the middle tablet, then I can go up.
Yeah. To protect the olfactory nose.
And then I can come forward. Okay. Then I can use the second incision. And then you join the incisions. So this normally we do it with a cautery. Because the blade many times doesn't cut through very well.
This is versatile flap. This is very, very important flap based on the sphenopalatine artery designed by Haddad Basagawe, very close friends of draft. And Stamberger.
Elevator.
Yes.
Just normal. So make sure the perichondrium gets lifted. Once the blood vessels will be in the perichondrium.
Yeah, mucopericardium elevated.
Otherwise, the mucosa will bleed like this tip.
Yes.
So you have to make sure the incision is deep enough and then you have lifted the perichondrium.
See, the skull base surgeries, we are creating a defect and we should know how to repair the defect. We
Plug the
should
defect.
assess the defect size. We can take the flap based on the sphenopalatine artery, based on the anterior pudendal artery, and many flaps are available. Even pericranial flaps are available. So we can design, we should close the defects.
Elevator. Then there is also called a reverse flap.
Reverse header, yes.
So we have lifted it out. Do you see it?
Yes.
And you could
Yes.
probably
It's,
see the
X.
blood vessels.
Yeah.
Do you see these blood vessels? The
Yeah,
twigs
yeah.
have started to come.
Yes.
Okay. So the safest way to put it is into the nasomes. Right? And then we usually put a piece of Merosil on it.
Yeah.
And you can release it.
That is a sphenoid. We had to go laterally up to the pharyngeal canal. We had to dissect. Yes.
Merosil. So I'm just doing it as I would be doing a real case. And you just cover it up with a nice large piece of Merosil so that when you're using powered instruments, they
Ramandeep,
don't.
sir, there is a request for you to show the sphenopalatine artery
Okay.
foramen level.
I will. So you want me to show the
Sphenopalatine foramen.
Want me
Dissect laterally and show that.
elevator.
Yes. Thank you. See, that is a,
So see,
yeah,
see these are all branches of the sphenopalatine, and these are the vessels on which the flap is based.
can dissect laterally, can go up
Yeah.
to the pharyngeal canal. Yes.
I can come from the other side. I can show you the crista ethmoidalis, and then that will go into the sphenopalatine.
Okay.
That can also be done.
Yes.
But let me show you the septectomy first. So see this vessel right here,
Personally. Yeah.
right here. So we still lifted it. You can still open the sphenoid down.
Yes. Because after then they will be doing a shoulder osteotomy in that area to remove that sphenoid anterior wall. For skull base work, this is very, very important, wide exposure.
So you should not only know how to open the skull base, you should also know how to close it.
Yeah.
Both
After wide
sides.
exposure only, you can go towards the skull base. Yeah.
So you can take a ronger. I have an upward ronger, but you can turn it right down and then.
Now
you
he
can-
is doing a shoulder osteotomy. With the
And I can
reason-
also use a drill to widen it.
Widen it, yes.
So if I have to go to the clivus, I need this lower down.
Yes.
Okay. So now there is also
For the
something
PGs,
called
it is
a
very important. For the clivus, clivus is an important one. Okay, it is having a 3 parts: upper, middle, lower.
something also
Yes.
called the reverse flap.
Yes.
What do you do in a reverse flap? Just like I had made the incision for the hadad, I make the incision on the other side
Yes.
and I pull out the flap from this area, the posterior part.
Yeah.
Give me a knife. So the reverse flap we are using very commonly. We have published it also on our work on V3 schwannomas.
Rescue flap, no?
No, this is not a rescue flap.
It's
This
not.
is a reverse flap.
Reverse.
It gets taken from the other side.
Other sides.
So I'll tell you why. Yes. So normally we do this with a cautery.
Okay. Because this is very important. If you are not using cautery, there will be bleeding. The field will be messy.
Forceps.
Yes.
This reverse Haddad flap now is being used commonly after pituitary surgeries to cover the raw area caused by the Haddad flap.
Correct.
Because the post-op crusting is much less and the recovery is faster.
So I'm going to turn this. Can I have a better one second? Upward. So this covers the.
Eye area.
So it's mistakenly called the reverse Haddad. It's just the reverse flap.
Yes.
So we put one suture here, and this whole raw bone gets covered. And see the turbinate of the other. Now, okay, debrider straight.
And we can go for a binostril approach.
So I'm just going to remove the leftover mucosa.
Yeah. It's a rostrum of the sphenoid.
The line come. I'll show you the sphenoid osteo on the other side also.
Yes.
That's the superior turbinate.
Yes.
All this we are seeing from the opposite side.
Opposite side. So binostril. So nowadays we are talking about these binostril four-handed approaches.
Yeah.
So this is the
Merosi-
one.
If you have time, we will.
Yes.
So again, the same technique is followed.
Inferior portion of the superior turbinate should be removed. And after then we can see the sphenoid arch dilate. We can enter.
I'm just going to take this,
Yes.
fold it back so it doesn't come in my way.
Yes.
I'll be working from the other side. So again, decongestion, like on the other side, just press it a little bit, do some suction.
15 minutes. So,
Yeah, we'll be on time now. And it was amazing how everything was started on time, even yesterday.
yes.
So that
Karthi is
is
very
great.
sharp, sir. Professor
That
Karthi
is
is
something
very sharp.
we usually,
Yeah.
we usually don't see in conferences,
Yeah. He's staying here, I think so.
Okay, so I should be able to see the natural ostia. There it is. Can you see it?
Yes.
What is the lower limit of opening that sphenoid ostium?
We can go lower down.
You can go down to the
Down.
nasopharynx, doesn't
Okay.
matter.
So here it is
that,
very important. The sphenoid os is 1.5 centimeter above the nasopharyngeal opening.
One, correct.
So we are doing in some case we are doing nasopharyngectomy for cancers. So we can go down. Nothing will happen.
Correct. Okay, elevator. And can I shift to MR8? So I'm just going to get the inferior turbinate a little out of the way. Again, gently, so I have more space. That is the natural
Sphenoid
ostia.
os.
Just creating some space for my burr. Irrigation bump up. So I have a landmark on the other side.
Yeah.
Just going to get rid of the mucosa. This is used with the coabulator. Microdebrider.
So the sphenoid rostrum is in the view. We have to remove that to get the wide access.
This is called the keel.
T.
So
yes.
right now what we have is called the owl's eye appearance.
Owl's eye appearance.
So owl because the nose and the two eyes.
Yes.
So I'm being a little radical on this side. Again, for beginners, don't insert the microdebrider into the sphenoid sinus.
Just imagine about a bird. So now it is like a beak. We have to remove the beak.
Yeah.
Also, eye already we have entered, and now we are removing the beak. It's a rostrum of the sphenoid.
These are very high speed bursts. And this bone is usually
This is osteotomy we
sphenoid is
have to
very
do.
thick.
Yes.
So I would like larger burr here for quicker work.
More than
Many people used to.
So only 12
Yes.
minutes.
I'm not drilling that as yet.
Yes,
We will
yes.
see that and start to remove it.
Yes. Now he has removed.
More than intersphenoid septum, this rostrum, you always feel the midpoint of sphenoid sinus.
I'm going to clean my endoscope once so that you can see more clearly.
Okay.
So see this septum told you it's going back and it's going to the other side. So the
Yes,
septum is here. So the right side sphenoid is smaller actually. If you have a an OD on this side,
Yes.
I should be on the other side also. Now see the rostrum has become loose. You can use we use your burr
Yes.
thicker so that I don't damage your.
Cold steel better, sir. Just 10 minutes more. Yeah. Thank you. He's using a through cutting.
And be gentle with your instrument, sir. This bone is very thick. You will ruin your instrument. That is the sphenoid. You see it?
Yes.
Debrider. So I'm going to trim the sphenoid mucosa. Shift over the brighter. I'm trying to demonstrate this case as I would do it in actual life.
Yes. The ball probe, can you show the cella planum,
Yes.
emosia, clivus?
So now
See,
we can see the intersphenoid septum.
Septum, yes.
It is not straight.
Now the ideal instrument is through cutting forceps.
Yeah, so we have diamond burrs for this area. We rapidly take it down when we are doing pituitary surgeries. Otherwise, a thick true cut, because this bone cannot be thick. So this is the clivus.
Yes.
We do get CSF leaks out of this area. This is the area.
Cella,
And above that is the planum.
planum sphenoidum. Tuberculum cella, please show that.
Yeah, that is the optic nerve.
Yeah,
Do you see
optic
it?
nerve.
And the keratooptic
Carotid.
recess, once I drill this and make it flush, I will be able to see it. You can see the blue hue of the carotid.
Yeah, yeah.
You see it?
Cavernous.
So since this was an anode, optic recess would not be very clear.
Yeah, yeah.
Okay, I'm just going to remove the sphenoid.
Now the
Ostia,
postgraduate
the-
is very important. Cella, he has shown the above one is called as planum and below one is called as clivus, and the blue area, cavernous area, and the optic nerve above, between the optic and the carotid, that is the optico-carotid recess.
So I've just trimmed out the
Using
septa.
through cutting forces, because the
Through cut.
attachment could be towards the carotid. We have to be careful. Before doing the work, we have to peel off the mucosa, sphenoid mucosa.
Mucosa, correct. Because this mucosa bleeds a lot. It takes you 10
Remove the
minutes
entire
to stop the
mucosa.
bleed.
This is skull base. wound.
Forceps upward.
Yeah.
So normally we lift it off with the elevator and then try to get it out like that.
Yeah. Now peel off entire mucosa. We can see the anatomical landmarks.
So again, skull base surgery is not a quick observation surgery.
Yes, yes. It's not mucosal preservation surgery.
Yeah, it is very
Yes.
different scopic sinus. Give me a straight fossa. So I'm using a combination of straight and upward.
Both are through cutting.
And see how, no, this is Blexley.
Lexley.
It's not holding. And same thing with the other side. We try to get it out in totality. See how it comes
Yes,
out in
yes,
totality?
yes. Great, sir.
And you gently, you have to like move it backward, forward, gently, and then that is the only way you can. And then you need to re-hold it. Again, I'm doing this exactly as I would have done a real surgery. And see the lowest most part is coming out now.
Yeah, yeah. So
And
writing
there
this
is no
net
more mucosa
floor.
now. Or mucosa now. There. That is how you take out the mucosa in one piece. Because if you shred it, it is very difficult to make the bone bare all around.
6 minutes.
Do you have a larger burr? So this burring on a MR8 laga do. On a MR8 handpiece. To your question, how lower we can go will depend on your access.
Yeah.
For your surgeon, for your neurosurgeon, so it won't hit here. This has to be taken down lower.
Yes.
Otherwise, their instruments are going to get stuck here because you are going to have a suction, a curate,
Yes, yes.
and then the endoscope.
All the septation should be removed.
Yeah. It should be one cavity.
Yeah, yeah.
And normally in pituitary tumors, this bone, the sella bone will be very thin because the tumor tends to grow outwards.
Yeah.
And this hump leads to, otherwise it will disturb your neurosurgeon. So we need a bigger
So
burr here.
many times neurosurgeons are very specific about the MRI, but here CT is also important to see the
It
body
is very important
situations.
because it is you who
CT
is going
and
to
MRI
navigate.
both are important. Ramandeep sir, 5 minutes.
Yes. Roger. So I would make this flush and then I would thin out the sella. And sella is thinned out with a diamond burr,
Yes.
not with a cutting burr. Because if
diamond,
you-
yes.
Dura. And then bleed going to start and then your surgeon is going to get angry at you. So you have to give him as clear a field as possible. So normally a coarse diamond works best here. We don't have that, but that's okay. Opening the sella was not on the. So a diamond burr would actually make this flush.
Yes.
Stop bleeding, because diamond burr stops bleeding not only by heat, but also by pushing the bone dust into the Hertzian system. That is very important to know.
4 minutes.
Okay. Drill.
If you are showing the landmarks, it will be useful, sir.
Jiva, help her. So this is a cutting burr. For beginners, no, do not use this the way I am using it. Do you see your sella is exposed?
Yeah. Sella is exposed. Yes.
You can still get this, have to get this bone. That is the key.
Here the dura is having a double layer, industrial
Yeah.
and periosteal
Yeah.
layer. 2 layers are the meningeal layer and industrial layer. So it is very thick, but even though we have to use only the diamond burr, not the cutting burr.
Not the cutting burr. Because the cutting burr will go through.
Yeah. So since the dura is having double layer, we have to be careful. We have to create a U flap to see the pituitary.
So flaps again, different surgeons have different preferences.
Yes.
Some use the flaps, the others don't use the flaps.
Yes.
So basically that is, I will drill this low.
What you are
Upper
straight
part
away you
also-
are seeing is the anterior pituitary. Just behind that, there is a posterior.
So that would complete this part. Back to the nasal cavity, elevator.
So in the sphenoid, can you show some the anatomical landmarks, sir?
1 second, let me get to the
Okay.
sphenopalatine. Knife.
2
Knife.
minutes more.
Yeah. Now you will make me do things which I normally don't.
Sorry,
But
sir.
we respect that you respect time.
Yeah.
So crista ethmoidalis is a bony landmark
Yes, sir.
which points us towards the sphenopalatine foramen.
Foramen.
Elevator. Is the picture focused?
Yes, sir. Very well. So we have to demonstrate the sphenopalatine foramen. That is very, very important. And here we can do endoscopic sphenopalatine artery ligations and posterior nerve neurectomy. Agils is here. Agilas Sami. Posterior nerve neurectomy.
Ball probe, please.
And if you are dissecting towards that, we can see the median nerve also. It's a sphenopalatine. The palatine bone is a beautiful bone which is having a horizontal and the vertical part. The vertical
That
part.
is the sphenopalatine
Yes,
artery.
sphenopalatine. Great, sir. Great, sir. We are able to appreciate that area.
Now this will have multiple branches.
Branches, yes, sir. Beautiful, sir.
Just
And
so you see there, it's a branch here, it's a branch here.
yes, yes.
Also.
Here, if you are putting a clamp, that is a sphenopalatine artery ligation for epistaxis uncontrollable.
And that's the sphenopalatine foramen.
Artery, yes. Foramen.
The sphenopalatine foramen will go behind the maxillary antrum
Maxillary antrum.
into the pterygopalatine
fossa.
fossa,
Yes.
which contains the sphenopalatine ganglion.
Yeah, ganglion.
So that is the artery. So you
Yeah.
can put a clip here,
Yeah.
and that
Yes.
would be.
Yeah, great, sir.
I think is up for dissection. I mean,
Great, sir.
right? Thank you, everyone.
Yeah, great, sir. Able to appreciate the clap, sir.
Very good.
Hello, sir. Ramandeep,
Yes, please. Yes,
there is
sir.
a standing ovation for you. Please, request, it is a request. Please, get up. For Ramandeep. Sir, just watch the TV, sir. Great, sir. And we are thanking the anatomy department, forensic department, and the PIMS
Department
and
of
by Karthi.
Anatomy and DNT and Tronic and Olympus.
Sir, thank you. On behalf of Alaigal 2025, I must thank from my wholeheartedly
Thank you, Doctor.
the
Thank you.
Department of ENT, Department of Forensic Medicine, Department of Anatomy of Pondicherry Institute of Medical Sciences for arranging the excellent cadaver lab today, and it is a real treat to watch for us. Everybody agreed with that.
Yeah.
Thank you very much. Dr. Sittananda is totally organizing from there with the help of the Anatomy and
Tamil
Forensic Medicine Department.
Very
Thank
good,
you.
Doctor.
And thank you, Olympus, and thank you, Medtronic. Thank you.
Thank you so much,
Yeah.
sir. And thank you to our chairpersons as well.